Assalamu alaikum. My name is Dr. Bushra Saeed, and today I am going to discuss with you about the initial evaluation and management of status asthmaticus in children. This is my disclosure statement. So we'll start with the definition of status asthmaticus. So definition of asthma severity, it differs according to severity of the disease. Status asthmaticus or acute severe asthma, this is defined as a condition of progressively worsening bronchospasm, which is unresponsive to standard therapy. Then acute severe asthma, if it requires admission to PICU, this is called critical asthma. And when the critical asthma requires endotracheal intubation and mechanical ventilation, this is called near fatal asthma. Risk factors for the near fatal asthma, if there is a previous attack with admission to the ICU, respiratory failure and mechanical ventilation, if patient is having seizures on syncope, if PCO2 is more than or equal to 45 millimeters of mercury, and if there is a history of high consumption of beta agonist, beta dose inhalers, underuse of steroid therapy can also lead to near fatal asthma. There are certain psychosocial factors like denial or failure to perceive the severity of illness, associated depression or psychiatric disorders. If patient is non-compliant to the therapy, dysfunctional family unit, and if there is intercity residence, this can also lead to severity of asthma. Near fatal asthma is more common in non-white, black, and Hispanic children than in the white children. Coming to the pathophysiology, this slide is really important because if we have a knowledge of pathophysiology of asthma, only then we can do proper management of asthma. So if you look at this picture, this is the upper part of the picture, this is normal airway. Look at the regular margins and the normal contour of the airway. So what happens when there is an antigenic and topical insert? When this insert is there, there will be mast cell stimulation. Mast cells in turn lead to release of histamine, leukotrienes, and prostaglandins. And there is release of many of the inflammatory cells. All of these inflammatory cells and inflammatory mediators, they lead to inflammation of the airway. With the inflammation of airway, there will be bronchospasm, there will be mucosal edema, and there will be mucus plugging. And this is really important to know because we have to work on these three factors during the management of patient with status asthmaticus. So when there are pathological changes in the airway, it will lead to airflow obstruction. When there is airflow obstruction, there will be premature airway closure on expiration. This will lead to dynamic hyperinflation. Intrinsic PEEP will be generated, and this will lead to hypercarbia. Then dynamic hyperinflation or air trapping can also lead to ventilation perfusion mismatch, which is causing hypoxemia. And hypoxemia is the hallmark of status asthmaticus. Patient clinically can present with cough, wheezing, worsening respiratory distress, and initial presentation can give clue to the potential respiratory deterioration. But there is one thing to know. The degree of wheezing does not correlate with the severity of the disease. Because if the patient with severe asthma can have silent chest, there will be no wheezing, but the patient is in impending respiratory failure. Then on examination, patient could be tachypneic. He will have diaphoresis. There will be increased use of accessory muscles and nasal flaring. Tachycardia is really important. This is a usual physiological response in status asthmaticus, and it can result from a number of factors. These could be due to secondary to anxiety, due to acidosis, fever, and hypoxia. Then there will be presence of pulsus paradoxus in patient with status asthmaticus. So what is pulsus paradoxus? In the normal patients, there is a change in systolic blood pressure between inspiration and expiration, and this is only around 5 millimeters of mercury. When this change is more than 10 millimeters of mercury, this is called pulsus paradoxus. And this happens in patient with status asthmaticus. This change becomes more than 10 millimeters of mercury. So pulsus paradoxus is an important clinical sign for patient with status asthmaticus. We should do complete neurological assessment for early signs of hypoxia. So if your patient was initially active, now he is becoming agitated, irritable, or comatose, it means his hypoxia is worsening. There are certain red alert signs which are showing that patient is developing severe respiratory compromise. One of these is silent chest. There will be increased respiratory effort, and it usually precedes respiratory failure. Patient will be agitated, dyspneic. There will be altered conscious level. He or she will be unable to speak more than 1 to 2 words at a time. There could be central cyanosis, diaphoresis. Patient will be unable to lie down. And now the pulsus paradoxus is more than 25 millimeters of mercury. PCO2 normalization or hypercapnia. So why the PCO2 normalization is a red alert sign? So what happens when the patient is tachypnic? He is washing out carbon dioxide. When the patient starts to deteriorate and his conscience become compromised, so carbon dioxide start to rise. When it start to rise, initially it will be normalized and then it will lead to hypercapnia. So if the patient was initially having low carbon dioxide, later on the carbon dioxide is normalizing, this is not a reassuring sign. We have to be cautious in this patient that he is in impending respiratory failure. He can develop bradycardia or there will be severe hypoxia. So this is a picture showing the pulsus paradoxus. The lower picture is that of a normal patient. Look, there is no change in the blood pressure, systolic blood pressure between inspiration and expiration. What happens in the pulsus paradoxus? This is difference is more than 25 milliliters of mercury. How can we assess the severity of asthma in the emergency department? There are different scores to assess the severity of the asthma. One of them is modified Becker score. This uses the 4 parameters. One is respiratory rate, second is wheezing, third is IE ratio, and the fourth one is accessory muscles. Respiratory rate, if it is less than 30, there is no wheezing and there are no use of accessory muscles, if it means your patient is stable at present. But if the respiratory rate is increasing, wheezing is now becoming on expiration, and now both on inspiration and expiration with the IE ratio will be increased more than 3, and there will be use of accessory muscles. It means patient's asthma is getting severe and he may need admission to the hospital or may need admission to the pediatric intensive care unit. A score of 4 or more is moderate status asthmaticus, and 7 and above, it means patient is needing ICU admission. Then there is another score which is called the clinical asthma evaluation score. This is using some other parameters. This is also using PO2 and cyanosis, along with that inspiratory breath sounds, accessory muscles, expiratory wheezing, and cerebral function as well. So if the patient is on room air, no cyanosis, inspiratory and expiratory breath sounds are normal, cerebral functions are normal, it means the patient is good. But what happens when the patient gets severe asthma? In this patient, initially the patient will be desaturated in the room air. And with the increased severity of asthma, patient will be desaturated even with the 40% oxygen. There will be marked expiratory wheezing. There will be maximum accessory muscle use, and he can be irritable, agitated, and he can develop coma in the later stages. So for the clinical asthma evaluation score, more than 4 score is impending respiratory failure, and 7 and above means patient is in respiratory failure. So we have to act accordingly. Status asthmaticus is usually a clinical diagnosis. Investigations are usually not necessary, but you can get ABG analysis. This will give the objective data for initial hypocapnia, and then you can monitor it for the later on if the patient is becoming normocapnic and hypercapnic. It means the patient is developing worsening AV obstruction. Electrolytes and complete blood count for any underlying infection. Radiography is usually not needed to diagnose asthma. But if you are considering the patient has consolidation or pulmonary edema, then a radiograph can be obtained. Electrocardiography is required usually for the patients who are admitted in the PICU with the critical asthma and or asthma therapy. Spirometry with the peak expiratory flow rate. This is used to estimate the degree of the AV obstruction in response to the therapy. But this is used more so in the emergency department with the acute asthma attack, and this is less useful in the ICU patients. In the emergency department, since hypoxia is the hallmark of the status asthmaticus, so supplemental oxygen should be started at the earliest possible. And our goal is to maintain the saturation more than 92%. For the bronchospasm, nebulized beta agonists such as albuterol, these are the most commonly used first-line therapy, and beta agonist therapy should also be driven by the supplemental oxygen. For the moderate to severe acute asthma, they should receive a dose of systemic steroids in the emergency department, and it should be done prior to the second dose of albuterol. We can also use oral prednisolone or intramuscular dexamethasone. Then inhaled or nebulized anticholinergic agents such as ipratropium bromide, these are proven to have a role as adjunct to the treatment of asthma exacerbation in the emergency department. And if your patient is not responding to all these therapies, then we can use magnesium sulfate in the emergency department. And if it has been used, there are studies that it will show that use of magnesium sulfate reduces the hospitalization rates in patients with a moderate to severe asthma. Admission to the hospital. When we have to admit the patient of asthma to the hospital, There are no standard indications for admission, but these are loosely defined. We can include this if there is inadequate response to initial 3 or 4 aerosol treatments, if there is relapse of respiratory distress within 1 hour of receiving treatment, if there is persistent oxygen saturation less than 91% on room air, if there is need for oxygen therapy, and there is significant reduction on the PEFR, especially with a poor response to the bronchodilators. Then there are psychosocial indications, like if there is unreliable family support or being unable to comply with the outpatient treatment, and there are multiple visits for the same episode, then we can admit the patient in the hospital. In the intensive care unit, there are certain general management, and then we have to do the specific management. In the general management, all the patients who are needing admission to the ICU, they should be monitored continuously by saturation. Continuous respiratory rate monitoring should be done, ECG monitoring should be done, and non-invasive blood pressure monitoring should be done. For sicker patients who require frequent blood sampling, we can use the indwelling arterial catheter. And for the patients who are on respiratory failure and requiring the mechanical ventilation, we may use central venous access for these patients. What are our goals of therapy in the ICU? Our pharmacological targets are, first one is to improve the oxygen delivery. Then we have to relax the bronchial smooth muscles. This can be done by acting on the beta 2 receptors and acting on the M1 receptors. Third part is we have to attenuate the underlying inflammation, and we have to institute vigorous pulmonary toilet for this patient. As I discussed earlier, hypoxia is the hallmark of the pathophysiology. So supplemental oxygen is considered standard therapy for children with the status asthmaticus. Hypoxia can result from a number of factors. This could be secondary to ventilation perfusion mismatch. This could be due to alveolar hypoventilation. And this could also be secondary to hypercarbia. So humidified oxygen should be used for bronchodilator nebulizations and continuously between the treatments. So patient with a critical asthma, usually they are tachypneic. There is increased insensible water loss and there is decreased oral intake in this patient. So they are generally regarded to be as volume depleted. So we should do some degree of volume expansion for all the patients. But always maintain a careful balance to avoid overhydration. Because due to overhydration, there will be increased transcapillary fluid migration, there will be alveolar flooding, and some patients may in turn lead to pulmonary edema and worse clinical outcomes. If the patient is in ICU with a severe respiratory distress, we can keep the patient NPU for some time and put on isotonic IV fluids, unless his respiratory condition is stable enough that we can start with the initiation of enteral nutrition. Steroids. Steroids with a critical or near fatal asthma should be administered by the IV route as compared to the oral route and or IM route in this. It is preferred to be by the IV route in the ICU. Inhaled steroids has no treatment role in the treatment of hospitalized patients, and the duration of therapy, it depends on the severity of the illness and the clinical response. Because sometimes the patient clinical symptoms improve, but still there is airway inflammation. So we have to continue the steroids even after the patient's clinical symptoms are improved. Beta agonists, these are the mainstay of therapy for the management of the asthma in patient with a critical and near fatal asthma. What is the role of beta agonists in the management of asthma? Beta agonist causes bronchial smooth muscle relaxation, thus causes bronchodilation. They will increase the diaphragmatic contractility. They will enhance the mucociliary clearance, and they will inhibit the bronchospastic mediators from the mast cells. So in the end, they will prevent the inflammation in the airway. We can use inhaled beta agonist, we can use IV beta agonist, we can use subcutaneous or oral routes. The preferred agents are salbutamol and terbutaline because they have relative beta 2 selectivity. So the side effects due to beta 1 stimulation will be avoided with these agents. So dose of this inhaled nebulizations again can be used by the continuous nebulization. You can use intermittent back-to-back nebulization, or you can use the meter dose inhalers. Dose for the continuous nebulization is 0.15 to 0.5 mg per kg per hour and better to use through an infusion pump. Intermittent nebulizations are given 0.15 mg per kg and it should be used as weaning from the continuous nebulizations. For MDI, use 4 to 8 puffs, 100 microgram each per dose. And the another important thing is MDI. If you use MDI with a holding chamber, it is almost as effective as the nebulized salbutamol in younger children with a moderate to severe asthma exacerbation. Then if there is a no response to the inhaled steroids, we can use the IV beta agonist in this patient. And IV beta agonist should not be given routinely in the acute exacerbation. This is used in patients only who are unresponsive to inhaled beta agonist and in patients in which the nebulization is not feasible. Which patients are these? These patients are intubated patients and the patients with a poor air entry. The preferred agent used is IV terbutaline, and we give a loading dose of 10 microgram per kg over 10 minutes, then followed by continuous infusion at 0.1 to 10 microgram per kg per minute. While using the beta 2 agonist, we have to keep in mind certain side effects of the beta 2 agonist. So there would be tachycardia, there could be increased QTC interval, there could be dysrhythmia, hypertension, diastolic hypertension. That is why we do the continuous ECG monitoring once the patient is in the PICU and he is on inhaled IV beta agonist. A common adverse effect is hypoxemia. Then, because of the excessive CNS stimulation, there could be hyperactivity and tremors, nausea with vomiting. Important side effect is hypokalemia and hyperglycemia. And hypokalemia is really important. We have to monitor the potassium levels. And another important thing is with hypokalemia, there could be worsening of cardiovascular side effects. So, for another drug for the bronchodilation is ipratropium bromide. This is beta 2 agonist for acting on beta 2 receptors. This drug is acting on muscarinic receptor. This is a muscarinic antagonist. It acts on the M1 receptors. It decreases cyclic GMP, thus decreases the intracellular calcium and thus leads to bronchodilation. Usual dose is 125 to 500 microgram, inhaled every 20 minutes for up to 3 doses. Then subsequently you have to give every 4 to 6 hourly. Keep in mind the side effects. Side effects could be dry mouth, bitter taste, flushing. This can also cause tachycardia and this can also cause dizziness. There is an important side effect. Sometimes there is a unilateral pupillary dilatation because of the local spillage of drug during nebulizations in the eye. So after inhaled agonist and IV therapy, the other drug which can be used is magnesium sulfate. Mechanism is it also inhibits the calcium influx into cytosols, thus leading to smooth muscle relaxation. It also increases beta 2 affinity for its receptor, thus potentiating the effects of the beta 2 drugs. It inhibits the histamine release from the mast cells. Give it as a bolus dose 50 mg per kg over 20 to 30 minutes with a maximum of 2 grams. The important thing during for giving magnesium sulfate is you have to give slowly over 20 to 30 minutes because if you give rapid IV bolus, this can lead to hypotension in the patients. You can repeat the magnesium sulfate once or twice after 4 to 6 hours. Methylxanthine agents. These agents are caffeine, theobromine, and theophylline. This is used in occasional selected patients who are failing to respond to any therapy previously used. So we can use this theophylline in this patient. Mechanism of action, this also causes bronchial smooth muscle relaxation, but it has added anti-inflammatory and immunomodulatory actions. It is also known to augment the diaphragmatic contractility and increase the respiratory drive. But the side effect with this drug is it has a very narrow therapeutic index. So you have to monitor the drug levels of xanthine while using the xanthine. The therapeutic window is 10 to 20 milligram per ml, but usually overlaps the toxicity, which usually occurs more than 15 milligram per ml. Helium oxygen mixture. So if we have used already methylxanthine, still the patient is not responding to the drug, another gas we can use is helium oxygen mixture. Helium has the benefit is that it has low density. It reduces the Reynolds number. When it reduces the Reynolds number, there is reduced likelihood of turbulent flow, thus facilitating the laminar flow. This will in turn lead to decreased work of breathing in situation associated with high airway resistance. So this is why helium oxygen mixture can be used in asthma or even in upper airway obstruction. This has a proven role in adult patients, but there are only some anecdotal reports which suggest the heliox is associated with improvement in the pulmonary functions in children. We do not give the pure helium. We always use it with the oxygen. So it is given as a mixture of 80 to 20 or 70 to 30. So this has to be kept in mind because we are giving, there could be element of hypoxia while giving the helium. So we have to give to the patients, to those who are requiring only low inspired oxygen. Then there is a drug called ketamine. Ketamine is a dissociative anesthetic agent, but it has an added bronchodilator properties. The bronchodilator properties makes it an attractive agent, so we can use it for analgesia and sedation in patients who require intubation or mechanical ventilation. It should not be administered to the patient who are not intubated because it can lead to intubation in these patients. So it should be given to intubated. No, no, so if you have to give it to a non-intubated patient, better to give it in the PICU where there is availability of personnel who can maintain patient's airway. So if we are using drugs and patient is not responding, so with the drugs, we can use the trial of the non-invasive ventilation, provide respiratory support to the patient. Non-invasive ventilation with the critical asthma, it will also decrease the respiratory muscle fatigue. The mode we can use is bilevel positive airway pressure, or also called the BiPAP. BiPAP has two pressure. One is IPAP, second thing is EPAP. What IPAP does, IPAP overcomes the increased airway resistance and respiratory muscle fatigue. While the EPAP, it helps to offset the intrinsic PEEP and aids in the trigger synchrony. But one thing to be kept in mind while using the BiPAP is it requires patient cooperation and well-sealed mask. It may be difficult in certain anxious and agitated patients with the impending respiratory failure. So if the patient is unable to tolerate non-invasive ventilation, we can head on to mechanical ventilation. Indications are if there is poor response to initial therapy, if there is profound hypoxia which is refractory to oxygen therapy, if there is rapid deterioration in the mental status, carbon dioxide is rising, or patient has developed cardiopulmonary arrest. Our goals on mechanical ventilation is to reverse hypoxemia. We have to relieve respiratory muscle fatigue, and we have to maintain a level of alveolar ventilation which is compatible with an acceptable pH. So while ventilating a patient with the asthma, our goal is we have to avoid increased airway pressure. If there will be increased airway pressure, cardiac output will be compromised. And another important strategy while ventilating the patient with asthma, you do not target a normal PCO2. You target permissive hypercapnia. Because if you target normal PCO2, you will require fast respiratory rate, you will require high minute ventilation, and you will require very high airway pressure. And all of these strategies can lead to the development of the air leaks. Patient can have pneumothorax, pneumomediastinum, and there are high chances of mortality in these patients. Before intubation, you have to pre-oxygenate the patient with 100% oxygen. You have to anticipate hypertension because patient was breathing very high, insensible losses were very high, so patient could be depleted of fluids. So before intubate the patient, before you intubate the patient, you have to give adequate volume to the patient. Then for intubation, you use the cuffed endotracheal tube and the largest possible diameter should be used. You have to avoid antihistamine producing agents like morphine and atracurium because they will worsen the bronchospasm of the patient. The preferred agent for sedation is ketamine, and you can also use atropine, benzodiazepine, and the rapid-acting muscle relaxant like fucoronine for intubation of these patients. So after intubation, what ventilator settings should be used? So there is no ideal ventilator settings for the patient with the asthma. Ventilator mode can differ from individual to one individual to other individual, or even in a single patient, it can vary according to the stage of the illness. One mode which is used is pressure regulated volume control. What is the benefit of pressure regulated volume mode or PRVC is it has the advantage of delivering a constant tidal volume even in the phase of changing lung compliance and airway resistance. And the second important benefit is it has a decelerating flow pattern that minimizes the peak inspiratory pressures. So there is a controversy on the use of PEEP in patients with the asthma. Some patients say that some experts say that we should not use PEEP. Some use small amount of PEEP, but we should use low level of PEEP because it will minimize dynamic airway collapse and it will decrease the triggered work of breathing in the spontaneous breathing patient. PEEP should be set below the auto PEEP of the patient. Our principle for the ventilation is we have to maintain adequate oxygenation, permissive hypercarbia with a pH of more than 7.2. Adjust the minute ventilation accordingly. Give the slow ventilator rates. This is really important. Rate is considered because the patient is retaining carbon dioxide. We have to give increased respiratory rate. This is not the thing in asthma. In asthma, you have to give slow ventilator rates so the patient has adequate time for the expiration. Air trapping should be avoided. Prolonged expiratory phase and short inspiratory time. So normally we keep the inspiratory to expiratory ratio is 1:2. In asthma patient, we keep the IE ratio of more than 1:2. It should be kept between 1:3 to 1:4. PEEP should be set below the auto PEEP, and patient should be attempted to extubate as soon as possible. For monitoring for the patient on ventilator, close monitoring is required. You have to do frequent auscultations. Frequent auscultation will provide valuable information regarding the symmetry of breath sounds, for pneumothorax, for mucus plugging, and for the optimal length of exhalation. Then you have to monitor the peak to plateau pressure difference on the ventilator. This is also really important. This will guide you about the airway resistance and response to the treatment. If the peak to plateau pressure difference is normal, or there is no difference between peak to plateau pressure difference, it means the issue is with the lung compliance. But if the peak pressure, there is a difference between peak and plateau pressure, it means this is airway resistance, and we have to manage accordingly for this patient. Shape of capnography curve. This also provides the insight regarding the adequacy of the lung in time. I will show you through this picture. So this is a capnogram. The lower picture is the capnogram of a normal individual. So look at this capnogram. This is the point of expiration. During expiration, carbon dioxide starts to rise until it reaches to the maximum and then it plateaus. Unless the start of the inspiration, and during inspiration, carbon dioxide starts to fall down. What happens in a patient with the asthma? The upper picture is the patient with the asthma. So carbon dioxide starts to rise and it does not reach a plateau. It means there is incomplete exhalation prior to the previous inspiration. So this is the capnogram will be just like this. There will be rising carbon dioxide, and this is also called the sharp fin appearance for asthma patients. Complications on mechanical ventilation: patient can develop hypotension, patient can develop desaturation, could develop pneumothorax, subcutaneous emphysema, can develop cardiac arrest, and if we suspect tension pneumothorax, we have to treat urgently in this patient. So you have put the patient on the ventilator. No, you want to. No, you do not want that your patient should fight with the ventilator, and there should be no ventilator disintegration. So we should have to give adequate analgesia. Adequate analgesia will avoid tachypnea, it will avoid breath stacking, and it will avoid ventilator disintegration. The preferred agent is ketamine because of the bronchodilator properties. If we use it with the continuous benzodiazepine infusion, it can provide deep sedation while decreasing the chance of the post-anesthetic hallucinatory reactions. If we have to use other drugs like opioids, fentanyl is the preferred agent, but morphine should be avoided because morphine can cause the histamine release and then can aggravate the acute attacks. For muscle relaxation with a neuromuscular blocker, it should be maintained following the initiation of the mechanical ventilation until the satisfactory gas exchange and clinical stability is achieved. But patients with a significant hypercarbia during the ventilation, they require the continuation of the neuromuscular blockade to abolish the spontaneous respiratory effort, and thus this could worsen the dynamic hyperinflation. Inhalational anesthetic agents. So what is the rationale of using the inhalational anesthetic agents? So patients who are refractory to more conventional treatment modalities, we use inhaled anesthetic agents because of their bronchodilatory effects. This should be performed in a well-monitored ICU under the direction of the personnel who are experienced in the administration of these agents and who are knowledgeable of the adverse effects of these anesthetic agents. The drugs which we use is halothane, isoflurane, enflurane, and sevoflurane. And sevoflurane appears to be less noxious to human airways than is the isoflurane or enflurane. So this was about the bronchodilation. There is another part of the pathophysiology in the inflammation. There was increased mucus plugging in these patients. So increased bronchial secretion and mucus plugging, it also plays a major role in the continued deterioration observed in some patients. Mucus plugging in turn can lead to atelectasis of large segments, and this will worsen the heterogeneity of ventilation, and this will worsen the dynamic hyperinflation. So we should do the regular bronchial lavage with the mucolytic agents such as N-acetylcysteine and recombinant human DNAs. But for certain selected patients in which mucus plugging cannot be controlled with N-acetylcysteine on this drug, then we can use the bronchoscopy in this patient to relieve the airway plugging. So this was for my presentation. For take-home message, the prognosis of patients with a critical or near fatal asthma who receive medical therapy is excellent. The important thing is we should have a better understanding of pathophysiology. We should use appropriate ventilator settings and we should do aggressive pharmacological treatment. And if we use all these strategies, we can decrease the ICU mortality for status asthmaticus patients to almost zero. Thank you.